Everyone presenting in the trauma session come up. Dr. France will start with fundamentals, staying out of trouble with the most common fractures.
So, I got asked to give a talk about how to stay out of trouble treating cervical fractures. So it's not a very database topic, and I think once you get a little bit older, these are the talks they want you to give. And so, we fail a lot, and some of these might be my case, but most aren't, but I've treated these problems, and, we fail a lot on our road to success. So I'm gonna go over some subtle clues of instability that were missed. Understanding fracture patterns can be a problem. I'm going to focus a little bit on recognizing the limits of fixation, mostly in regard to facet dislocations, and then also being prepared to respond to the unexpected. And this is really a series of cases. So recognizing subtle clues of instability, we all do this with ankylosed spines, with a true rigid, bony, stabilized spine, but elderly spines that are stiff behave the same way. And this is often unrecognized. You can see in this patient, they're not ankylosed, but this spine doesn't move. And you can see the subtle clue of an extension injury, and you can even see some subtle fracture. This was not recognized at an outside facility. We received the patient after they cleared the collar, they dislocated and became quadriplegic. So these patients, these elderly patients behave like ankylosed spines, and we have to be aware of it. We also have to be aware of who's calling us. Many of you probably now receive calls from outside facilities. This was a call about a 66-year-old male, fell from standing normal, had a mild T1 compression fracture. They asked if they could just put in a collar and follow up in clinic. I'm being leery like an old fox, and I looked at this and I said, okay, there is compression, and it may be simple, but that to me looks a little bit wide. And I said, this patient needs to come to the hospital, and there's the MRI. You can see this is not a T1 compression, but this is a flexion distraction injury. And if you look at the CT better when you get a chance, you can see subtle clues of facet injury. This is not a stable injury by any stretch of the imagination. We were told they were neuro-intact, but the patient tells you when they were injured and fell, they had tingling and numbness in the hands. It took 5 or 10 minutes to go away. This patient also had a mild cord injury, and this is why that's in the classification. So be leery of what you're told. Look at the imaging, and we learned that as residents not to be trusting, and this patient got a fusion. Understanding fracture patterns is important to avoid mistakes. We're all sort of aware of this injury, the floating lateral mass. This is a 2-level injury. This is a paper with not large numbers, but most papers on this injury have small numbers, and they all say the same thing. If you try to treat this with a 1-level fusion, your risk of failure is pretty high. Not all of them fail, but this is a 2-level injury. Even though the subluxation occurs at the caudal end, it's a 2-level injury. Similarly, in the cervical spine, unlike the thoracolumbar spine, subtle neurological complaints have meaning. In the thoracolumbar spine, we rarely see a normal CT that has significant injury, but that's not true in the cervical spine. This is a 69-year-old, very healthy, active male, a good skier, failed skiing, came in with neck pain, left arm paresthesias. The radiologist read this CT as negative, and even in retrospect, I would agree. This C-spine was cleared by the trauma service. We never saw him until a month later. But what they forgot is that they did image the patient, but this patient had focal neurological deficit. They had neck tenderness, and although this patient was cleared radiographically, they weren't cleared clinically. And, we need to do the same thing. There's a reason we do what we do, and they need clinical clearance, even if they're a physician that you don't want to inconvenience. Because he came to see us a month later. Now he still has left arm paresthesias, neck pain. He now has wrist extensor and grip weakness. You can see the traumatic disc herniation and the disruption of his ligaments. And you can see this is an unstable level on flexion extension and gets an ACDF. Recognizing the limits of fixation. This is really the big one, and I have most examples on this because In cervical facet dislocations, we have a lot of choices. We can go anterior, posterior, and all these things can work pretty well. We have a lot of ways to tackle this problem as long as we're aware of the pitfalls of treatment. So our goals are simple: cord decompression. This can be done with a traction reduction. It can be done by removing disc herniation anteriorly. We can realign it. That may complete our decompression. It may require a discectomy if there's anterior disc on the cord. Then our stabilization can be done anterior, posterior, or both. We have to decide how to do it. So there's a lot of acceptable means in order to do this. You can do a traction reduction, then MRI to assess for disc herniation. At that point, your choice is to stabilize anterior, posterior. If there's disc herniation, it's going to force you anterior. If there's not, you can do a posterior stabilization. If traction fails, then you may want to consider an MRI and consider a posterior open reduction if there's no disc herniation. If there's disc herniation, again, you're forced to the front. Some people choose to go straight to the OR and say, I'll just do an anterior discectomy, I'll eliminate that problem, then I'll do an anterior reduction and stabilize them anteriorly, okay? That's assuming there's no contraindications to anterior fixation alone. You'll see this is where people get into trouble. This is probably the main area that they don't recognize. So if an MRI is the first step and there's no disc herniation, you can do an open posterior reduction. The one absolute no-no is open posterior reduction without MRI. So anterior stabilization, we get to leave them supine, the approach is easy, we all like it better. And it's usually biomechanically adequate. The problem is if we overstract the discs and we lose the ability for the facets to abut one another and resist translation, that thing's going to fail. So that's not only true if we overdistract, but it's also true if we have large facet fractures. It's also true if the end plate's fractured and won't support our graft. Multiple examples of this. This is the biggest problem we see all the time because everybody likes to leave the patient supine and do a simple surgery. This is failure to recognize a vertebral body fracture. Looks okay initially, and it's doomed to failure. This is a case where they failed to recognize the facet fractures and the inability to resist translation. I don't have the initial films, but this is early post-op. It's already failing translationally, and this thing is going to fail dramatically. So if you recognize that, you've done this and you recognize that, you need to take that patient back the next day and deal with this with additional posterior surgery. This is the 21-year-old who had upper extremity paresthesias. This particular surgeon chose not to do an MRI, go to the OR, do an anterior discectomy to address the disc problem, and anterior reduction. The problem is when you do an anterior reduction, verifying that reduction can be very difficult. On the bottom right, you see one of our West Virginia patients. You're not seeing a 5/6 reduction on that patient. So you have to verify it. Today we have the advantage of an O-arm. And if you have that patient, you may need an O-arm spin because this patient had an anterior discectomy but no reduction. They thought they were reduced, not reduced. Another problem with anterior fixation. So, you know, the problem is I would rather do an anterior if I don't have the contraindications. But in reality, I'd be hard-pressed to find a failure of posterior fixation. I'm sure they exist, but all the failures I see are from anterior alone surgery. If you go anterior, you can go anterior posterior. Lastly, be prepared for the unexpected. This is a 62-year-old ankylosed spine. We know these are dangerous. He's neuro-intact. He's not displaced at this point, but they're dangerous. The surgeon took it to the OR, did everything right, did a glide scope intubation, put him in tongs, got baseline pre-flips, did a Jackson table flip. Pre and post CT, C-arm pictures looked pretty good, and the neuromonitoring stayed stable. They did an in situ fusion. They did recognize that it had sagged a little bit into extension, which they often do. Did an in situ stabilization. Things were going well. When they were finishing the posterior stabilization, getting ready to close, suddenly they lost signals. They troubleshot, the signal persisted. So the thought was this was sagging into extension, and the cord compression was likely posterior, and they were able to recognize this immediately, do a posterior decompression, And you can see they were probably right when you can get a better look at sagging into extension, and you can envision where the bone might have been having a pincer effect into the cord posteriorly, post-op MRI. So be aware of this, prepare for this. The monitoring in this case helped. The patient had some persistent deficit, but probably could have been way worse. So in summary, care of cervical trauma, those of us who do a lot, it can be really rewarding. The indications are pretty clear and the outcomes are pretty good. But there are pitfalls that can change the first premise completely. You have to recognize nuances of each fracture pattern. You have to understand the limits of fixation techniques. An anterior fixation for jump facets can work, but it has its limits that you have to recognize and then understanding your own limits. Thank you.
All right, good morning. My name is Ryan Spiker. Appreciate the opportunity to speak today. We're going to talk about some complex scenarios, really looking at multiple fractures within the cervical spine. These are my disclosures, none of which are pertinent today. So, an outline, we're going to talk about some basic principles. We'll talk about non-contiguous cervical fractures, so upper and lower. We'll briefly touch on contiguous fractures in the cervical spine, and then some take-home points. So you're on call next week. This comes in. You have this C1 burst, associated C2 fracture, also has the C7 vertebral body fracture with the facet injury. There's a lot going on here. So how do you think about it? And so with these complex injuries with multiple fractures, I think it's important to go back to the basics. So remember to look in other areas of the spine, not just the cervical spine, because they may have even other fractures beyond the two that you've already identified. And then go back to some of those basics of making sure you look for the verts, make sure you look for your screw paths. When there's a lot going on, I think sometimes people jump quickly to conclusions about what they're going to do. You want to make sure you're taking care of the patient, not just the fracture. So these are high energy injuries, and it require you to be a physician and not just a surgeon. And then remember those goals of care, those basics: decompress, align, stabilize. In the upper cervical spine, I think in general that posterior fixation can be biomechanically superior in a lot of situations. In the subaxial spine, I think when you can go anterior, there are benefits as to the ease, and you can keep those in mind, but each fracture is certainly going to take a very nuanced approach. When we look at non-contiguous fractures within the cervical spine, we can see that they're rare beasts. So these are not things that we're seeing on a weekly basis. Some studies suggest it's around 2 or 3% of cervical fractures will have a second cervical fracture. They're high energy injuries, so about 3/4 of these patients will end up having either cranial or thoracic injuries. And in the small series that have been reported, their outcomes appear to be relatively similar to other types of cervical trauma patients. It's important to separate intracervical non-contiguous injuries from spinal non-contiguous injuries. There's a lot of literature on spinal non-contiguous injuries. We're at the cervical spine meeting, but I think they'll allow me to speak briefly about thoracolumbar trauma and just say those injuries are certainly much more common. So CT studies suggest about 10%, MRI studies suggest 20% of non-contiguous injuries if we're looking at the entire spinal column. When you're looking at non-contiguous cervical fractures, I think it's important to think about the primary versus the secondary injury. The primary injury is really where there's the most neurologic compression, it's the most unstable, it's the injury that's really getting your attention and you're most concerned about. The secondary injury is obviously less so. There are two similar injuries, they both have similar amounts of instability and compression, then in general the one that's more cranial or more proximal is going to be the one that you're going to address first. But by identifying that primary injury, you can start to come up with a plan, and you don't want to sacrifice that plan. That's something that you're going to want to really focus on. With non-contiguous fractures, you have to consider, am I changing my approach because there's two fractures? And I would say, again, you're going to focus on the primary injury first, and then you can treat each injury the way you want to treat it. I think if it's a very kind of 50-50 type of fracture, it's a subaxial burst fracture that you could go in the front and do a corpectomy, you could go in the back. If you're already in the back for another injury, maybe it pushes you and makes the tie go to the runner. But I think it's okay to treat each fracture the way that you prefer and feel comfortable treating it. So in a case like this, you have upper cervical instability, you have a lower cervical fracture. I think it's reasonable to go and fix the C1-2 first, then come down, and since you're already posterior, you can get fixation posteriorly of that fracture, which otherwise at C7 may be an anterior corpectomy. Contiguous fractures, there's really not a lot of data about these. So we know that if you have associated facet fractures next to burst fractures, those certainly confer some instability, but the instability is not always greater than the sum of its parts. So if you have non-operative, basically stable fractures, and you have a lot of those, that doesn't suddenly become operative. And there are multiple case reports about spinous process fractures, TP fractures. These non-operative fractures, even if there's 10 in a row, they still remain non-operative. And so you really just want to treat the areas of instability. You don't have to treat the adjacent level just because there's a fracture if it's not a fracture that's conveying instability. So I'll go through one other case. So this is a 27-year-old female that came to the University of Utah, had been on a trampoline, had a fall, had right arm paresthesias and some weakness, was basically intact with the exception of her right C7, which was weak and numb. Otherwise healthy, 27 years old. These were her presenting films. She's got this C1 burst fracture. She's kind of lost her articular pillar. She's got a C6-7 facet fracture with a little bit of anterior translation of that SAP and some foraminal stenosis that kind of explaining her weakness. So she comes in with these injuries, and so I start to think, how do I want to think about this? And so for this, I think the primary is a little bit unclear. So her symptoms are really coming from her C6-7 injury. I think radiographically, her C1 injury is more concerning for stability. So I start to think about how do I want to address each of these fractures. For C1-2, do I want to do a fusion? Do I want to do an osteosynthesis? Do I want to do a halo? For 6-7, I can go anterior, I can go posterior, I can treat it in a brace. And as I start thinking about this for this person, I think, well, she's young. I'm really worried about her radic, her stenosis at 6-7, and then late deformity at C1-2. So I can achieve kind of both of those goals by doing kind of a small surgery, an ACDF at 6-7, and then a halo to prevent that late deformity at C1-2. And so this is her immediately post-op and then at 6 months, and she did well. And so again, I think just taking each part and then putting together a plan that's logical and kind of systematic. So when you have a spine fracture, it's important to look for others. So things move really fast in the more complex traumas, and I think we tend to jump to conclusions. So double check your verts, double check your screw paths, double check your imaging, look for AO injuries, determine your primary injury, and really prioritize that in your surgical plan. But you don't have to sacrifice your secondary injury in your plan. And then just remember that the instability is not always greater than the sum of its parts. And so just because there's a fracture in an adjacent level doesn't mean that you have to continue to include those levels. All right, thank you.
Thank you. And on behalf of my co-authors of our paper that highlights controversies in the management of odontoid fractures, I would like to thank the Society for this spectacular activity. We had no trouble finding controversies to talk about in the paper. So odontoid fractures are certainly among the most common fractures that you will encounter in clinical practice, and nearly all of the clinical questions will pertain to type 2 fractures. And a great deal of interest in the literature over the last 2 decades has been directed at the concept of a fibrous union. The ideal outcome from a type 2 odontoid fracture, whether it is treated surgically or non-surgically, is to achieve a bony union. But although surgery offers higher rates of fusion, it comes with the risk of surgery, and here is where the catch-22 comes, that the patients who we frequently see are the elderly. They may be on Eliquis or have a lot of medical comorbidities, and they're the exact patients that we would rather not operate upon. So if a patient, after being in a collar 3 months, develops a fibrous union, is that considered to be a satisfactory outcome after type 2 odontoid fracture? And although controversy is not eliminated, I think in this particular area there is a consensus that is emerging that a fibrous union is a satisfactory outcome that is generally associated with a good clinical outcome and similar clinical measurements. Now, when we're talking about developing a fibrous union and being happy with it, we are speaking about patients that could be treated either surgically or non-surgically. We're not talking about patients with significant displacement or spinal cord compression that certainly need surgery. A controversy, though, that has not been settled is what is the effect of surgery and does it reduce mortality? Odontoid fractures are not entirely benign, and if you look at the data, like hip fractures, there's a significant mortality in the first year following fracture. So a surgeon has to weigh the benefits and the risks of whether surgery is appropriate for a particular patient, and that may depend on the patient's medical comorbidities. It should be kept in mind that non-surgical treatment has its own comorbid or own problems. Putting a patient in a halo vest is very difficult for an elderly patient that you may develop dysphagia or respiratory compromise, and even collars have their own problems. So when surgery is needed, there is an anterior option, the odontoid screw, or posterior options. The decision as to which way to go is much larger a discussion than for this talk, but suffice to say that a much smaller number of patients are appropriate for an anterior approach because you have to have the right alignment and you have to have the right patient body habitus. So one area that we identified that has been discussed more recently in the literature is that the odontoid screw is not an entirely benign procedure for elderly patients, and these patients seem to have a much higher rate of dysphagia. And I can say anecdotally that many of my colleagues have had second thoughts about offering odontoid screws for elderly patients. It turns out that odontoid screws work great for patients who are the same patients who would have probably healed very well in a halo. This is a very interesting idea, and there are a few papers now that are looking specifically at the idea of maybe giving a patient an internal halo, putting in posterior instrumentation with the intent of coming back to remove them once the odontoid fracture heals. And the advantage of this strategy is that you do not lose the range of motion of the C1-2 joint, or at least you have the potential of maintaining motion, which is a very important motion segment. Another advantage to this approach is if you needed more fixation, there's no reason that you would not be able to go up or down to achieve additional points of fixation. I think that the idea of navigation being of benefit in performing surgery in the upper cervical spine should not be an area of controversy, and I think that it has shown its value in lowering the rate of vertebral artery injury and achieving more optimal fixation. Even in anterior approaches, I think that this can be a helpful technique. If the setup that you see in this slide seems like a lot of work, I will point out that using 2 fluoroscopies for an odontoid screw is also not very much fun to set up. This topic, the topic of optimal graft material, continues to be a debate in all forms of spinal surgery. Certainly, iliac crest autograft is still the gold standard, but I think fewer and fewer doctors are actually going to the iliac crest and harvesting. They're using demineralized bone matrix or other bone graft substitutes, and the literature is still really all over the place in terms of head-on-head comparisons and what really is an acceptable or desirable bone graft. Thank you.
Yeah, thanks so much. Just a quick note, I'd like to thank Brian and Adam. We did a special topic review for the Publications Committee, and these gentlemen were tasked with talking about cervical facet fractures and dislocations, and they actually wrote the chapter on this. I'd like to thank them for that. We're going to focus primarily on facet dislocations because of the limits of time. These are my disclosures, none of which have to do anything with the talk. Let's start with the case. This is an older gentleman who was in Asia C after a motor vehicle crash. And you can see his facet dislocations there at C6-7. You got a lot of questions. Should we use steroids in this case? Should we reduce the spine? Should we get an MRI before we reduce the spine? When should we reduce the spine? Should we get it done as soon as possible? What surgical approach should we use for stabilization? And does it matter, all this matter, based on his classification or his level of neurologic injury? Well, there's a huge variation in facet injuries. And as you can see here, sorry about the slide there, we're talking about facet fractures, and there's 10% of all cervical spine injuries. However, 75% of dislocations are facet injuries, and these can have devastating consequences, as you can see with a facet dislocation. Our treatment goals should be improvement of neurologic function to try to enhance recovery as well as we can and prevent deterioration. We should also look at skeletal realignment and stabilization, which hopefully can accelerate our rehab goals to prevent late pain and prevent late deformity. Now, there's no question on timing. We should get these done as quickly as possible. And Dr. Failings published this with Staskis now over 10 years ago, and they found a statistically significant difference in the number of AIS grade 2 improvements in patients who were operated on less than 24 hours versus those who were operated on greater than 24 hours. So we want to get to these as quickly as possible. Now, in my hands, that's closed reduction. And so as a result, we need awake cooperative patients. We need an experienced team, no evidence of head trauma or skull fracture, obviously, but it can be effective in up to 80% of unilateral and bilateral dislocations. The published complication rate in the literature in an awake, alert, cooperative patient is very low. And Jerry Grant published this from the Harborview series a long time ago now, where we reduced 82 patients in a mean of 2.4 hours, and closed reduction was successful in over 95% of them. Only one patient deteriorated 6 hours post-injury, though there were a lot of disc injuries seen on these post-reduction MRIs. Only one patient deteriorated. So this led the joint section to form a guideline that's now about 10 years old, saying that you had an 80% successful reduction rate, 1% permanent neurologic sequelae, but there was a 2 to 4% transient neurologic issue rate. There were several case reports documenting worsening, but these were only subtle case reports. And if a patient fails closed reduction, then you should go to MRI. The cases that were presented, most notably from Dr. Eismont's series, were all reduced posteriorly without an MRI. And these were reduced posteriorly, and there was worsening of a disc herniation, suggesting that if you're going to take somebody for a posterior reduction, you should get an MRI to make sure you don't have a disc herniation before you do this. What is the incidence of disc herniation? The series early papers out of Jefferson showed that there could be up to a 50% incidence of post-reduction traumatic disc herniation. And there was, Alex looked at pre-reduction and post-reduction and found that there was an increased incidence of post-reduction disc herniation, but there's actually no correlation between the presence of disc herniation and neurologic worsening in these patients. Now, this is another paper that's out of France, and what they did was they took 17 consecutive patients and actually reduced them in the MRI scanner. And what you can see here is reduction from 15 to 95 pounds. And what they found is that most of the patients had improvement in canal diameter, and none had worsening of their canal size, and none had neurologic worsening associated with these disc protrusions that you can see on the MRIs. Now, as a result, there's a recent study that's probably worthwhile reviewing in the literature from the European Spine Journal. There's a 41% incidence of traumatic disc herniations, but neurologic worsening after closed cervical traction is less than 1%. As a result, I would say that data supports closed reduction prior to MRI in the cooperative patient, and you want to stop if there's new or worsening symptoms and go to the MRI. Post-reduction MRI helps us determine the appropriate surgical approach in these patients. And so we go back to our case, and we can see how with reduction, we get a nice reduction at the C6-7 joint right there. You can see that there. And an MRI post-reduction does not show ventral compression of a disc herniation in this situation. Now, does reduction always work? This is an Olympic aerialist that we took care of who came in with this C3-4 Asia A injury and immediately was not moving. But despite traction to 70 pounds over 1 hour, we could not get her reduced. Unfortunately, we couldn't get an MRI on her because the MRI scanner was blocked up. So we went and opted for ventral reduction. Now you can see the mechanism you use for ventral reduction, and you can put your pins in with the tips convergently and the ends divergently, and go ahead and put the Caspar reducer on and go ahead and reduce this patient. And that's effective in patients when you want to do an anterior reduction. In this patient, we went anterior, couldn't get them reduced still, took out the disc, went ahead and did a posterior reduction, and then we came back and did an anterior, posterior, anterior. Now, the surgical approaches, we talked briefly about anterior, posterior, and combined approaches. And John went through this pretty nicely, so we'll go through this briefly. There's a lot of evidence for an anterior approach and a lot of evidence for a posterior approach. The pros of the anterior approach have ease of positioning, less pain, it allows for reduction, but you have to be aware of over-reduction, difficulties reduction, and a cervicothoracic junction could be hard to fuse. The pros of the posterior approach is straightforward, biomechanically restores the posterior tension band, it has biomechanical superiority. There are papers that suggest that anterior can work, but you have a failure rate. This is a paper from the group in Vancouver suggesting a 13% failure rate with ACDF for facet dislocations. And the risk factors for this were facet fracture and superior end plate fracture. So our surgical options, anterior approach, if a disc herniation is present on MRI, potentially stand alone in the young neural intact patient, there's no end plate fracture, but beware of over-distraction. Posterior approach, it's a workhorse for these injuries. You can reduce people easily, you can maintain alignment, and it's robust in cord-injured patients. And a combined approach, when there's disc herniation present in a cord-injured patient, if it's irreducible and there's a herniated disc, you may require an anterior-posterior anterior, as we showed, and this allows for anterior excellent realignment and robust fusion. It may decrease the number of posterior instrumented levels as well. So in this case, we went ahead and proceeded with a posterior instrumentation, as you can see here. And in summary, closed reduction without manipulation has low risk when following a protocol. The risk-benefit ratio may be low in severe spinal cord injuries. Of course, in intact patients, you may have to use a slightly different protocol, using an MRI, then open reduction. However, there are a number of series that show you can still reduce these patients, even when they're neurologically intact, without deterioration. Thank you for your attention.
Hey, thank you so much to the organizers for including me in this. And I just want to thank one of our chief residents, Greg Kazarian, who's here, who did an amazing job putting this paper together for the special issue and also putting all of these slides together. Thank you, Greg. So I'm going to talk about everything other than fractures, and this is going to be a return to play following injuries to the cervical spine. And as background, I think as most of us would agree, contact sports probably make up the most common cause of cervical spine injuries outside of the fractures that we've talked about up to this point. And generally speaking, trying to figure out how to get people back in a safe and timely fashion is challenging. If we think about it sort of globally, the three things that you really want to think about that can make you comfortable in terms of getting people back to play is, are they asymptomatic from their injury? If they had any neurological dysfunction, has that returned to normal? And do they have painless range of motion of the cervical spine? If those three things fit, then for the most part, getting people back into their activities in sport is very reasonable. However, I think it's very important to understand that there's significant variability. So if we think about where does that variability come from, there is a variability in the injury type and severity. So not all injuries are made the same. And then there's individual specific risk, and we'll get into the details of both of these things. So in terms of the injury type and severity, these are sort of some of the common conditions. And again, I'm not going to talk about fractures because that's been talked about, but you can sort of divide these injuries into sprains, strains, and contusions, burners and stingers, cervical cord neuropraxia and transient quadriplegia, and then spiritacular spine. And these are significantly different injury patterns that suggest a completely different severity. So understanding the injury type is critical. And then in terms of the individual specific risk, if there's history of prior injury, how long have the symptoms been there, are there any anatomic or congenital variations, and then what is the sport that they're looking to return to is going to have a significant impact on the treatment recommendation. And that's what makes sort of this decision-making around return to play so challenging. In general, I would say, break down your return to play recommendation into injury-specific, patient-specific recommendations with that thought of what we talked about earlier in terms of range of motion, neurological recovery, and no neck pain. In terms of the specific considerations, again, I'm going to talk about each one of these first four because we've heard a lot already about number 5. So let's start with sprains, strains, and contusions. I think in general, if there's a more severe injury, which often happens with these ligamentous issues, such as a fracture or neurological deficit, that's what's going to impact the return to play recommendation. But if you do have a patient who has specifically an isolated soft tissue injury without any neurological deficit, this is probably the one that really follows that initial rule that we talked about. In general, I think that X-rays are always going to be necessary. You're going to want to get X-rays. You're going to want to make sure that the cervical spine is stable. But once the symptoms have subsided, which could be a couple of weeks all the way up to a month to 6 weeks, and there's no instability, these are generally patients that we could feel comfortable getting to return to play. Burners and stingers have some variability in them. In general, when we think about burners and stingers, separating burners and stingers from a cervical disc herniation or transient quadriparesis is extremely important. The management of burners and stingers is going to be really highly dependent on how many episodes there have been in the past. In general, at least for my practice, a first or second time event, which is of short duration, okay to immediately return to play. Anything that lasts more than 24 hours, that's somebody that we're going to want to get imaging on, including advanced imaging like an MRI. And then if there's a third event, then you sort of want to think about exactly what's going on. It's not an absolute contraindication, but maybe a relative contraindication to keeping somebody out of play for a little bit. Cervical cord neuropraxia and transient quadriplegia, I think, are the most important things that you don't want to miss when you're thinking about return to play. These are acute transient neurologic injuries to the cervical spinal cord and often can cause sort of this burning and pain, which can sometimes be thought of as a burner or stinger. But these are patients, especially if they have repeated events and deficits that last for more than 36 hours, this could be somebody that would be an absolute contraindication to return to play. And I'll talk a little bit more about a consensus that our society put together around return to play in these patients in particular. Spiritacular spine, just quickly touch on this. Spiritacular spine is a very specific set of things, which is you've got canal stenosis, you've got a straight cervical spine, and you've got radiographic evidence of some minor trauma, and somebody who's involved in a sport where they are doing activities that are going to involve head-first contact. In general, for me, this is an absolute contraindication to return to play because there is a significant risk of cervical cord injury with collisions. There are multiple other factors that influence return to play recommendations, including congenital and anatomic variants, issues at upper cervical levels, a lot of things that, I'm already out of time, so we're not going to get into. But in general, if you have an opportunity to look at this paper, I think, we try to go through them as best as possible. I just want to, quickly end with 2 slides. The CSRS consensus recommendation around transient quadriparesis and cervical cord neuropraxia. This was a study led by Greg Schroeder, and they did a really nice job. And this was with patients with prior transient quadriparesis events who are now asymptomatic. There was a strong consensus to let people return to play based on their canal diameter, and specifically a canal diameter greater greater than 10, unrestricted return to play. Canal diameter of less than 10 was a relative contraindication. If you had transient quadripresis, were asymptomatic, had T2 cord signal changes that were resolved, then if you had a canal diameter of greater than 13, return to play was okay. Less than 10, again, in this patient, absolute contraindication. And anything where there was continued T2 signal change was considered an absolute contraindication. In terms of operative recommendations, I think I'll just skip the slide. We can talk about it in the time we have, and I'll stop there. But thank you again. Hopefully we got everything covered.
Thank you to all our speakers. We'll go into a few cases.
So this is a case of 24-year-old MBC, neuro intact, some midline tenderness he was placed in a collar. This is a video, I'll let it play through, but so pars fracture on the right, C2. A little bit of distraction at C2-3, disc space, and displaced fracture on the left as well. So isolated C2. Not a great place for the vert either. So in our institution, they get CTA if they have any injury through the transverse frame, and so CTA was obtained. Won't show that. But the MRI scan confirms that there's a bit of a discal ligamentous injury at C2-3, really capacious canal. Neuro intact 24-year-old with this injury. So, John, you want to, is this a collar? Is this a reduction halo? Is this an anterior C2-3 ACDF? Is it posterior C1 to 3? Is it a lot of options? How would you
This
approach
is probably like a 2A because it looks like it has flexion but no translation. Fracture's pretty horizontal, so back in the day when we would reduce them with traction, this would be a contraindication to traction probably. So we used to put them in traction, reduce them, and put them in a halo. You know, I'm not adverse to the halo, but everybody else is so adverse that we've used the halo less and less. This would have been a patient we would have put in a halo. I'd put this patient in a collar now that he's healed, the disc ossifies. They all have disc injury, so when we get an MRI and say, what has disc injury, only the non-displaced ones don't. So I think this is pretty well aligned. I'm probably putting this in a collar unless they're a multi-trauma, and I think it'll help them mobilize by fixing them. And I'd have to look through the images. If I was going to fix it, this might be amenable to direct osteosynthesis, at least on the one side, maybe not the other, but I'm putting this in a collar and upright films weekly for the first 2 to 3 weeks, and if it stays minimally displaced, it'll heal satisfactorily.
Next, John.
I agree with the analysis. I think the comment about halos is, although they are considered old-fashioned, but the people who do the absolute best in halos are very young, and this is a patient in their 20s, and I think that I would feel more confident that it is being immobilized in a halo than a hard collar, and I think that that really would be the best non-operative management. If it needed operative management, if the anatomy is amenable to it, a C2-3 ACDF would be an excellent way that would avoid touching the C1-2 segment, which is a much more morbid loss of motion.
Tim.
I think you put this in a collar. My question to John is, do you treat this in a clavicle-based collar like an Aspen, or you do CTO type thing?
I mean, you want extension, so really a CTO is probably better, but frankly, I would just put it in an Aspen collar.
Okay. And it depends on what the upright x-ray looks like. If you see that C2 vertebral body sublux, then you know you're getting more distraction. But again, these do heal predictably, and for any residents or fellows, if you're on your boards, this goes into a halo, okay? The correct answer here is a halo, and then close follow-up.
That's a good point. So it's canal expanding. What's acceptable alignment in the collar? If they're displaced, how much? How do you measure that?
I don't know, that's a good question. I don't know that we know a real number, but, this is angulation, no translation. I'd probably set 10 to 15 degrees of angulation, and translation probably just 2-3 millimeters or so is fine. Even with the translation, some of these ones that are translated but not flexed, oftentimes like the disc space will be narrowed, and those quite often they auto-fuse. So I'd accept, up to 2-3, maybe even as high as 5 millimeters of translation.
Right.
And I measure that at the vertebral body level.
Yeah, I agree with those measurements. I don't use a lot of halos in my practice, despite the fact that I showed one in my talk. But it's a once every few year type of event. But I think the young patient who fails non-operative treatment for this, that has 4 millimeters of translation, or an odontoid, is really an ideal patient for it. If not, I think an ACDF at 2.3 is totally reasonable. But this is going to get a Minerva for me. I guess my question for the panel would be, do you guys ever use Minervas, or do you feel like an Aspen is easier or better? I know the literature on it is pretty weak, but I do use a Minerva for things like this.
Minerva's an Aspen's definitely easier for sure.
Yeah.
The Minerva, you can exert more force on the neck relative to the chest, but boy, they do hate them. And, in young patients, they'll tolerate them like a halo, but the elderly patients get the cubit eye and things. So in the older patients, I almost never use them. In a young patient, because you can mitigate the risk of decubit eye and things, it's a reasonable choice. Probably a better mechanical choice.
Dr. Dailey, any thoughts?
Yeah, no, I agree with the concept of a Minerva in this situation, to try to get as much extension and try to get that odontoid angulated posteriorly as opposed to anteriorly. I think that would be a good case for it. And it's going to be relatively well tolerated in a 20-year-old kid.
Yeah, I don't disagree. I mean, first thing I'd do is send these images to Tim and ask him what I should do. But no, I would, though, in this patient, given the kyphosis and posterior distraction, be more worried that this is going to fail non-operatively than I think some of the guys on the other side feel. And I would have a low threshold to do a 2.3 ACDF in this patient, just given the amount of distraction posteriorly, and then you've got that disc, which just looks like it's kyphosed, and that increased width in the back. I know it's a capacious canal, so I'm not worried about a neurological injury, but I just worry that this won't heal.
So this, I didn't share the upright x-rays, but a little bit of focal kyphosis, no translation. So this went on to reduce pretty nicely, and this is in the OR, so it makes you wonder, could you have just reduced and haloed this? That's what you're thinking here. Not a lot of distraction or kyphosis there at the C2-3 disc. But you could palpate the fracture, and there was bony apposition enough for ORIF. And so lag screw technique over-drilled the posterior elements with a large frag 4.5, and then got a lag screw across, and then took it down to C3. So, thoughts?
Why take it to C3? Because I think if the anatomy is amenable, your screws are lagging across the fracture site. Why take it to C? The facets weren't dislocated. Why take it to C3?
That's a great point. So the C2-3 capsule should be intact. Most of the discs look pretty good. Maybe screw across both sides bilateral. A 24-year-old bone, that probably would be okay, huh?
John, doesn't that angulation of that disc sort of worry you a little bit, that there's more of an occult sort of disc injury there at 2-3?
There's always an occult injury in Tangmans unless they're non-displaced. So the anterior longitudinal ligament's intact here, and you can use that anterior longitudinal ligament and basically ligament ataxis. When you screw them in the back and you hold it down and you lock in the fracture, it's like a pelvis fracture with an open symphysis. You can just plate the symphysis, and the posterior ligaments close down and will heal okay. So you can use the posterior ligaments. In this case, you can use the anterior ligaments, close it down, and I wouldn't expect it to sublux. This is different than one that may have had a lot of translation to it, where the anterior longitudinal ligament and anterior annulus is also disrupted.
Just a quick question. I've only done this once. It's a pretty rare injury, but I was a little underwhelmed with the purchase. Did you have really good purchase as you did that ORIF, and did that influence your decision to go to 3?
Yeah, good question. So that first picture with a curette or something in the fracture site, I kind of measure out how much bone you'll actually have and really almost go bicortical with this. And 24-year-old bone, if you really lag the posterior cortex and you're not purchasing the screw threads on that, but you're actually getting across the fracture, it really sucks it down. And so it's the contralateral side that starts to book open because it's such good fixation in young bone. So pretty happy with the purchase. To John's point, probably could have just done a screw across. Or actually, upon reduction in the OR, I kind of wished I'd considered them for just a halo. Like if I got that, I might have would have just said, let's just put a halo on.
I mean, the reality is of including C3, the morbidity to the patient, other than a little cost of some screws, is almost nothing. Like they're not going to miss that one motion segment. So I don't think it's a big issue.
I think we have another case here.
That was a great case. I think the key point there is the morbid approach is to go up to C1, and I think we're a little bit more on that tomorrow. 68-year-old male fall off bar stool, so put that in the frame already. Neuro intact with a small ICH. So this is the essential cut here. So again, 60-year-old male fall off bar stool with this stiff spine injury that's obvious at 4-5. You know, we talked about you want to do a pan scan of this patient because he may have thoracolumbar. It wasn't that high of a bar stool, but you want to be thorough. But also this type 2 odontoid fracture. So these are this is the pertinent image. I apologize for the video. Neurologically intact, 62-year-old male, John, France.
So this is a highly dangerous injury. I mean, that's what has to be recognized. Positioning on the table is difficult. They're often hyperkyphotic. You know, how you position their head, how you get them prone. So this is a multi-level posterior fixation of the subaxial injury because it's an ankylosed spine. You know, how you handle the odontoids is the next issue, because if we look through the imaging and he has motion still with the OC1 joint and the C1-2 joint, I'd want to preserve that for him. So what I might do here is fix the subaxial injury with multi-level, and I might connect him to the skull and take the skull fixation down at 6 months after the odontoid healed, because I would be leery of treating the odontoid non-op because there's going to be so much stress on it, but it might not be a bad idea. Your other choice is to flip him over and do an odontoid screw because his bone looks pretty good, but I might just connect him to the skull and take it down, no fusion to the skull, and take it down at 6 months.
I think that that sounds like a great plan. I mean, the key point to recognize is that this has a spine with dish. It's like an ankylosing spondylitis situation. It's going to be unusually unstable, and you have to take great care at not being too rough when you turn to the prone position. You should have pre-flip motors to make sure that there's been no compromise in the turn. So for the subaxial fracture, certainly a laminectomy infusion. I would not consider treating this from in front. I think that they do much better with the posterior approach, and you get more points of fixation. I think you have to treat the odontoid for the reason said, that since everything else is so stiff, there's going to be so much stress at the C1-2 level that it's very likely to fail. It's if you want to answer a board question, it probably would be to fuse up to C1 because that is the more tried and true approach, though I'm very attracted to the idea of trying to maintain motion at that level. But that's an experienced surgeon's level decision to make.
Dr. Spiker?
Yeah, so the one thing that I would add to this is to consider an anterior fixation to make the flip safer, depending on the patient. So this is a relatively common fracture in the subaxial spine in people with stiff spines. We see a lot of these extension injuries at 4-5 or 5-6. And depending on the patient, I think doing a single level ACDF is really low morbidity and really makes the most dangerous part of the case, which is positioning, safer. So for this case, because of the large osteophyte, that may dissuade me because suddenly that becomes a bigger surgery. But it's an important point, I think, to think about in general with stiff spines is does a really small anterior surgery make the difficult part of the case easier? And then for me, this is probably a C1 to T1 or T2. I'm going to make a really long construct here. I'm going to treat C2 operatively. I like the idea of going to the occiput and then coming back. You painted a picture of somebody who may not come back, so that pushes me to kind of do one and done a little bit, but it would depend on the patient.
If you're going to do that, Ryan, and you're going to open at C5, 6 and put a plate on for the flip, which I think is a very reasonable approach, you're at the same position for an odontoid screw. Why not put an odontoid screw up there? So I was going to take that strategy. I would probably put an odontoid screw up at the same time.
Yeah, John, I worry a little bit about an odontoid screw at the end of a rigid lever arm there. Odontoid screws are not as strong as we used to think they were. And I mean, there's good biomechanical evidence. I think that Rick Sasso published initially. They're only 50% as strong as the intact odontoid. So I think, if you're going to be posterior, why not just do it all posteriorly?
Sheeraz, anything?
Same, all posterior up to C1.
Okay, so this is what we did. So this is a very important point for residents and fellows. Have a couple people in your back pocket, okay, who you depend on and you can send things to. I swear I didn't send this to John France, but I thought he had a great idea. So we went all posterior, instrumented the occiput. Those of you who have worked with me, you see the occiput plate. That's what we use when we're not going to fuse. C1 lateral mass screws, and then all the way down. This video is not going to play, but if it did, it would show you that the odontoid can heal predictably as long as you align it. And then CT scan, I think it was about 7 months. We did a CT scan, and then we took the occiput C1 instrumentation out. Don't let anyone fool you. They never get normal motion, but definitely much less debilitating than occiput to cervical. And the nice thing about this was recidivism is real. He fell off again, and if the video played, you would see that the odontoid held up. So, okay, at this point, if anyone has any questions, we have about, 5 minutes. If you have any questions for the presentations, you can ask those or anything about the cases that were presented.
Jim, they may not get all their motion, but as soon as you take the plate out in the recovery room, they're loving you.
Andrew Cordova. At Andrew's Sports Medicine, I have a fair amount of professional and college athletes in my practice. One of the banes of my existence, and I'm curious to hear how each of you would counsel a patient for an MRI that was probably not indicated, was done. Probably patient has a component of diffuse underlying congenital stenosis with a superimposed disc herniation 4.556, canal diameter down to less than 8 millimeters, no cord signal change, negative exam. What do you tell them?
Yeah, I can start. I mean, I think that is that's what makes return to play so challenging. And I think most of those decisions are going to be based on kind of what the risk tolerance is, both on the side of the athlete, the side of the team, the side of the agent, the side of the family. I think you have to counsel them, and it's a shared decision. For me, the canal diameter that you're describing, if it's a collision sport, I'm saying you can't go back, especially at 2 levels. But if it's a sport that comes with a lower level of collision intensity, such like baseball or something, I would be okay with them going back.
Any other comments from the panel?
What about skiing? Because I struggle with skiing because, it's not a collision sport, but every so often there's a really big collision. How do you handle skiing in those circumstances?
Yeah, I mean, for me, I'm okay with it. It just depends what kind of skiing they're doing. I mean, are you talking about like a regular person skiing or an athlete skiing?
I don't know.
Yeah, I get a regular person skiing. I would just counsel them to, you just educate them on what they've got. I think for the most part, at least in my practice, most patients, once we describe the surgery to them and sort of getting rid of the risk, choose to have surgery done in a scenario that you've painted with an 8 millimeter canal. If there's CSF around the cord, I don't have that conversation with them. But if there's no CSF and they've got a canal diameter that's small, I don't use you could go paralyzed, that kind of, but I counsel them that if you have an injury, you're at greater risk. And then when we talk about the surgical options and sort of the recovery kinetics of surgery for something like this, especially in an anterior cervical procedure or a laminoplasty, most patients that I take care of will choose to say, I understand that I'm going to have surgery for this.
So back to skiing, it's collision versus contact sport, and totally different animals to me. And pro skiing is collision, not contact. And for my single levels, I've had patients that the NFL or other organizations will not let them return, so I have done single level cervical fusions and returned them to play without any issue. It's the multi-levels that become even more challenging. Thanks.
Dr. Phalanx?
Great session, really beautiful cases. I just wanted to survey the panel quickly on your thoughts on timing of surgery in cervical cord injury. Just going right down there. So obviously it's been a discussion point, lots of debate in the field, but what are your thoughts on the timing?
Based on his answer to the question, I think that's a trick question you're giving us. So, if I have a cord injury in my cervical spine, whether it's complete or incomplete, I want pressure off the cord as fast as I can. I'm coming in the middle of the night for all those patients. If I have jump facets and I can do a traction reduction and my MRI shows that the canal's open, I can delay the stabilization till the next morning, because used to be I had good teams in the middle of the night. I do not now, so I'd rather not. But if for me, incomplete cord injuries at the cervical level or complete, I'm coming in the middle of the night.
John?
I'm definitely in the camp of early surgery, and early surgery isn't 24 hours or 48 hours. It's as soon as we can get the operating room arranged.
I think there's a debate later in this meeting too on ultra acute versus acute, and I would be in the ultra acute, the less than 6 hours. I'm coming in and doing them quickly.
Yeah, absolutely, as soon as possible. I'm a big believer in traction, so as soon as you can get them reduced, get them decompressed, get them to the OR.
Yeah, I would agree, although the one caveat I would say is that if I have a patient with an acute central cord and then overnight they seem to be getting better, that's the person I would wait on for 6 weeks and let's see where you are. You're going to need surgery if you've got compression. That's the person I would sort of let cool off. So it's just scenario dependent.
Yeah, I think that's reasonable. I'll be interested to look at the debate this afternoon on central cords. I was just interested because we've come out recently with these guidelines, but it's ruffled some feathers, and there's going to be some letters to the editor back and forth, et cetera, et cetera. And just to be clear, I think one of the biggest challenges that we have in terms of timing and decision making is now dealing with older patients and geriatric patients with cord injury and medical issues. And although I'm a big proponent of very early surgery, I agree that 24 hours is not it's a continuum, it's not anything magic. But I also think that it's very reasonable in those patients to defer. That I just want to be kind of clear on that as well, because you have to use your judgment. And I think that's perhaps where some of the sensitivities have arisen, and there are concerns, I think, that people might feel that there might be medical legal issues if they were to defer in a medically frail patient. I just want to emphasize that I think it's actually correct medical management. You still need to use your judgment.
I think that there's a distinction to be made with patients that have partial cord injury and persisting compression of the spinal cord, like retropulsion of bone from a fracture, rather than a central cord situation where the cord may not be significantly compressed before the fall, and they're not significantly compressed after the fall, but they hyperextended and buckled in their ligament and transiently injured their cord. I think that there is less urgency to get it to the OR immediately in that patient.
In those patients, the amount of pressure on the cord is the same pre-injury and post. And so for me, I feel like I can let it cool off. If I get a central cord injury and there's a little disc, or I think something additional is compressing the cord more than it was before their injury, which may be not a true central cord, that patient I'm going to do more urgently.
Yeah, the excellent discussion, excellent topics. We're not going to go into the weeds about central cord surgery timing. Thank you to all the presenters, the moderators, the authors. We're going to go on with the next session. Thank you.